Okay, in this chapter, chapter 37, we're going to cover vital signs and measurements. So the different outcomes we're going to look at here are describing the 5 vital signs. The first 4 would include temperature, pulse, respirations, and blood pressure. And then we kind of discussed the 5th one already as being pain. So remember that pain would be addressed here if it wasn't addressed in the original chief complaint. If it's addressed in the chief complaint, you would probably get some sort of severity scale in the HPI or during that interviewing process. Okay, so we'll go through and we'll talk about some of the different ways to take a patient's temperature, the different types of temperature gauges that we have. We'll describe the process of obtaining pulse and respirations. We'll also talk about where they're kind of intertwined and related to each other. We'll go through and carry out the blood pressure measurement. We'll go through and kind of demonstrate that in class, but we'll deal with some of the terminology that goes with it here. We'll also look at something called orthostatic or postural vital signs. That has to do with people that come in presenting with dizziness or feeling lightheaded. Sometimes there can be a cardiac or even a neurologic underlying cause of that. And so there is a way to actually measure the blood pressure in different positions. And if there's a significant difference, that could indicate that someone's got a cardiac issue with that blood pressure. And so you'll hear them termed orthostatic or get orthostatic blood pressure, and that's what that's talking about. And then we'll talk about a few of the basic body measurements that we'll sometimes need to do. Okay, so the introduction here, we're looking at vital signs. Vital signs, accuracy is essential, and that is one of the measurements we're going to be looking at and stressing the importance of how important accuracy is. These vital signs are giving us an idea about that patient's overall health and health issues, and so it's important that it be extremely accurate. And so when we're looking at the vital signs, once again, we're looking at temperature, and we'll go through the multiple ways that you can obtain a temperature, pulse, the different areas you can obtain a pulse from, respirations, blood pressure, and then once again the pain assessment. Okay, measurements that would be included would be height and weight, and then in children we will look at taking the head circumference. We will talk about this a little bit more when we get into the pediatric chapter, so we're not going to deal with that too much at this moment, but there's a few other body measurements that we'll refer to as well. Now, when we look at vital signs, part of the reason why we take vital signs is, number one, to provide information about the patient's overall condition. You're going to take vital signs at each visit. It isn't something where you selectively don't do that or have times where you don't take them. The vital signs are important regardless of what the problem or regardless of what brings that patient to the clinic for that day or at that particular time. Vital signs are included in PHI, which is protected health information. So it's not something that you're going to share or walk around. You always want to try to be in a secure or private place while you're doing this. You don't want to necessarily, some clinics actually do have height and weight kind of out, but usually it's off to the side. Most places will actually have it in a closed room, and you would shut the door, and it would be considered part of the PHI, just like getting the chief complaint and the history of present illness would be. When we look for standard ranges, it will be important to note table 37.1 on page 739. It goes through and kind of goes from 0 to 1 years, 1 to 2, 2 to 5, 6 to 12, and then to adulthood. And you'll see that there are variations of pulse, but respirations tend to be higher with the younger individuals, and then will slow down as that individual gets older. So being familiar with the vital signs and some of the normal ranges for different age groups will be important. Okay, and generally, especially with blood pressure, you're going to establish a baseline when a patient comes into the clinic. The first time they're seen, you're sort of establishing a baseline so that as that person comes for return visits, you have something to compare it to. Okay, there is a list on 37.2, same page 739, or table 37.2 on page 739 that talks about some of the guidelines for OSHA. It gives us an idea of when we need to put gloves on and when we don't, and so that goes through and kind of gives us an idea of what we need to do as far as the as far as the PPI goes, or the PPE goes, as far as these particular patient contact situations that occur. You're always going to want to wash your hands before and after patient contact, regardless of whether it's a situation where you have to put gloves on or not. Gloves are appropriate for certain conditions. Anytime you do a rectal temperature, it will be important to place gloves on. If there's a situation where there might be a contact with open lesions or wound or a rash, you would want to put gloves on. Or if that patient is suspected of having something infectious, you would want to wear gloves as well. Okay. Okay. So now we'll go into the first vital sign, which is temperature. And there's a couple of words that are associated with this. The word febrile also indicates that an individual has an elevated temperature. So a lot of times in a description of a patient or a general inspection, you'll note whether or not that patient is febrile versus afebrile, because that's noting whether or not that patient has a temperature or not. Fever in and of itself is generally a sign of an infection. However, it can be a sign of inflammation as well. And there are certain inflammatory conditions in the body, certain autoimmune conditions like rheumatoid arthritis or lupus, where sometimes a presentation of fever will actually be there. Most of the time it's an infection, but inflammation can play a part in that as well. The word hyperpyrexia means an extremely high temperature. So you're looking at something at 104, 105 when you're dealing with that. Those are the ones you've got to cool down immediately. Otherwise, there could be repercussions from that. And so the word afebrile would then indicate a normal temperature. And so like I said, a lot of times you'll see that that person is alert, oriented, and afebrile, or you might see a description of 6-year-old male, sweating, fatigued, febrile at 102.5. And so you'll see both of those words used in the description. And when we actually look at what a fever is, it's sort of a balance between heat produced and heat lost. And so frequently the body will attempt to cool itself down. And so that's why you'll get chills, either sweating or chills associated with a fever. Prototypically, we measure in Fahrenheit, but Celsius can kind of go along with our metric readings. And so there is a table, 739 as on page 739 as well, 37.3, that kind of goes through and gives you basic Fahrenheit and Celsius degree equivalents. The following page, on page 740, actually shows you how to convert Celsius to Fahrenheit and vice versa. And so our normal oral temperature for Fahrenheit is 98.6, although people can go up or down a degree and be normal. That equivalent in centigrade is 37 degrees. So there will be a couple of questions on the exam that have you convert from Celsius to Fahrenheit and vice versa. I believe there's 3 of each. So when the test comes, just know that that conversion page is located on 740, page 740, and that you can plug that in, and you have the actual math measurements there to figure out how to go from one way to the other. We can do a few of them in class as well. The temperature routes are located up in the top corner, and we'll go through each one of these as far as different routes that you can actually measure a temperature on an individual. There's a couple of different types of thermometers. We do have electronic digital thermometers. They're much quicker and faster than the old mercury ones, where you actually had to leave it for 3 to 5 minutes in order to get an accurate reading. The temporal scanners are fast, but they're not as accurate. You're actually taking a temperature on the forehead and then moving it over the temporal area. The tympanics have become quite popular. Those are the ear thermometers. They are very fast, accurate, they're quick, and they're comfortable for the patient. However, it is important to make sure that the area fits snugly into the ear canal. If it doesn't, you might not get an accurate reading, as well as if there's an ear infection. That can sometimes affect the actual reading and cause it to be slightly higher than it normally would. There are disposable thermometers too. We don't generally use those in the clinic. Those are usually bought for lay people that don't want to maybe spend the money, $35 or $40 on one of the other ones, and they can get these cheaper. So at least it can give you a vague idea. You can stick these disposable ones on the forehead or in the axillary area, depending, but you're getting sort of a skin temperature. They're really not as accurate. And if it is exceedingly elevated, a lot of times they'll want to recheck it with something that's a little bit more accurate. They are cheaper. They give you an idea. You can dispose of them. And it does give at least an alternative if one can't afford to buy an actual digital one. We still use rectal temperatures as well, oral and rectal. Generally, the rectal temperatures, they are the most accurate. That's one important thing to note about taking a rectal temperature. Most of the time, it would be done in an infant or very small, like a toddler that can't actually hold, or if you don't have a tympanic one available. Honestly, the tympanic ones have become a little bit more commonplace. But the rectal ones are used. You can't really use the rectal ones in some of the kids under 6 months because the canal is too small. So sometimes under 1, they'll still do a rectal exam. And we'll kind of go through and talk about those guidelines. Oral temperatures are obviously easier to do too, but once again, there's an age group, the toddlers and below, where it can be difficult to do an oral temperature. They have to be able to keep it in their mouth for at least 10, 15, 20 seconds, however long it takes that digital thermometer to do the accurate measurement, and it must be placed correctly underneath either pocket, just off center on the lower jaw. You need to kind of keep it securely with the tongue and with the lips, and make sure you don't bite it with the teeth. And if you've had anything to eat or drink, hot or cold, or any smoking, you need to wait 15 to 20 minutes before actually taking it. So the orals, we have a couple of different kinds of oral digitals that you can use. They are easier, but once again, in the younger sector, some of the pediatric patients, you can't use the oral thermometers. So the tympanic ones, once again, these are kind of nice. They became real popular 10 years ago. They're like $35 to $40 to purchase. A lot of parents, that's what they opt to buy. And once again, they're probably the quickest, the easiest, the most comfortable. Just got to make sure that you have the snug, that it snugly fits in the ear canal. And we'll kind of demonstrate. With an adult, you have to pull the ear upward and outward. In a child, you have to pull the ear down and back because the canal is shaped a little bit differently. And once again, rectal temperatures, this is the most accurate. You have to use standard precautions. Generally, you place the patient on the left side, and you have to slowly insert the tip, hold the thermometer. You're going to put a little bit of KY jelly or some sort of gel on there. You're going to go about a ½ inch for infants and children and no more than an inch for an adult. Okay, and it's very important to hold that in place. It can be a little difficult sometimes when you have a wiggly infant, but if you do peds, they will definitely go through and show you how to do that. Okay, you can do an axillary temperature too. You can take one of the oral digital, one of the ones that you would use orally. You can put one of the caps on it. You can use those in an axillary temperature as well. But it is important to make sure that the very tip of the probe is in the middle of the axilla, and that the probe has to touch all skin surfaces on all sides in order to actually get the temperature accurately. These tend to run about a degree below, so it isn't ideal, but if you have a screaming child and you can't get them to do what they need to do, if you don't have one of the tympanics available, sometimes they will use axillary, but ultimately it isn't as accurate either. And then there's also a temporal. The temporal one, you stroke the scanner over the forehead and across the temporal artery. It is fast, but I've found that there's a lot of variability with this one. If the patient's sweating, you can't make good contact, and so these also aren't as accurate, but there are some places that do use these occasionally. Okay, next section after temperature is pulse and respirations. These two tend to kind of go together in some respects because they are interrelated, because the heart and the lungs work together and are interrelated. So generally, if you see an increase in one, you'll see a little bit of an increase in the other, or vice versa. There's generally about a 4-to-1 ratio between the pulse and respiration. That can vary just a little bit, but prototypically, if someone's got a 75 to 80 pulse, then their respirations are going to be somewhere between 17 and 20. So there's about a 4-to-1 ratio between the pulse and the respirations. When we're looking at pulse, pulse is sort of an indirect measurement of cardiac output. And when you look at what the definition of cardiac output is, we're actually looking at the heart rate plus the stroke volume. And the stroke volume is the amount of blood that is ejected per heartbeat. And so that's a measure of cardiac output. Okay. If the pulse is too fast, there's can be certain reasons for that. The word tachycardia, with a couple of these terms that we're going to come across, are things that we should have learned in medical terminology. Tachycardia means rapid heart rate or pertaining to a rapid heart rate, which is generally above 100 beats per minute. So if someone registers that, it would be considered tachycardic. Obviously, nerves or stress could do that too. It doesn't necessarily mean that there's a abnormality with the heart, but that term is associated with a heartbeat that is above 100 beats per minute. Then we have the word bradycardia, which is pertaining to a slower heart rate, which is generally under 60 beats per minute. So our normal range for heart rate, and this is an adult, okay, the other page that we talked about gives us normals for other age groups, but we're looking at 60 to 100 being the normal heart rate for an adult, or above 12. And under 60 would be considered bradycardic. Now, there are case scenarios where you can have athletes that are very healthy. They have a very efficient heart contraction because they exercise, do a lot of cardiovascular. And so sometimes people can run, in the mid 50s or low 50s, and that can actually be normal. So you'd have to make sure that if you got somebody that's got maybe a 57, 56 or 57 pulse, then you might want to ask them, a few questions, some other questions to see if, oh yeah, they run, 8 miles a day and they're healthy. It might not necessarily be problematic. If somebody has a health issue like hypothyroidism, or possibly is even taking medications that affect the heart rate, like certain hypertensive medications, then it could be medication induced. So it is important to ask a few questions that go along with that. And then when you're actually looking at the pulse itself, you'd want to look at not only the pulse rate, but also whether or not it's weak or irregular. So you're going to look at the quality of it, and then the regularity of it. Is it beating in a regular pattern, or is it an irregular pattern? Things like atrial fib can give a very irregular pulse where it's not in a regular fashion. And so it's important to note those things. Prototypically, you're going to use the radial artery, which is on the thumb side of the wrist at the very distal edge on the anterior portion of the forearm. That's prototypically where you find the radial artery. If you can't feel that, or it seems like it's difficult, there's a few others in the book, and we'll talk about those. In the beginning, it's good to count for a minute or 60 seconds. Once you get used to doing it, if you feel it for 15 to 20 seconds and the pulse is very normal and regular and it doesn't feel out of the ordinary, then you can learn how to take the pulse for 30 seconds and multiply by 2. In the beginning, we should work on doing it for a minute, but after that, you can start to find that as long as the pulse is regular, strong and regular, then it's okay to do that. If you feel something that's irregular or weak or bounding, I would do the whole minute or the full 60 seconds. Okay. Some other areas that you can, if you can't find the radial for some strange reason, you can go to the brachial artery, which is farther up in the arm in the crevice of the antecubital fossa, which is actually the one that you're listening from when you take the blood pressure. So the brachial artery, you can usually feel that there. Sometimes in infants, that's where they'll feel as well. You can use the apex of the heart, which is the point, the bottom part of the heart, and there is a pulse there, and frequently that can be used with infants as well if you can't actually feel the pulse. You can use a stethoscope in that area if you can't actually feel it or see it, but you can use a stethoscope there to listen to the heart rate at the apex. You don't generally do that with adults. You can usually find another spot, but infants, it can work. Some other arterial sites that you can use are the temporal area. Usually it's got a pretty definitive heart rate, as is the carotid, which is right by the throat. Just don't ever listen to both. Don't ever palpate both carotids at the same time. It cuts off the oxygen to the brain. The popliteal and the femoral are sometimes a little bit more difficult to feel. The femoral is in the anterior thigh area. and the popliteal is behind the knee. And so sometimes those are a little hard to find depending on the person and how deep the arteries are and how much adipose tissue they have. It can be a little bit tough to feel those. The two in the lower extremities down in the foot area, the posterior tibialis is near the Achilles tendon, and the dorsalis pedis is on the top of the foot. These usually can be palpated most of the time and give an idea of how well vascularized the lower extremities are. So now when we actually look at some of the devices that can be used, there are some measuring devices that are electronic. We can't count on having the availability of that, which is part of the reason why we put you through learning how to do these manually. They don't always have these devices available. A lot of clinics do, but you need to be well versed on how to do it in case it's not there. There are some electronic digital blood pressure machines or blood pressure cuffs that actually have some of these measuring capabilities for the pulse and for the respirations. There is something called a pulse oximetry unit, which is actually a little device that fits on the finger. It can also go on the nose or the earlobe if necessary, but it primarily is designed to go on the finger. And it's an infrared light, and it measures both the pulse and the oxygen levels. We'll have access to doing this when we get to diagnostic testing because we have some of these units, and you'll see how they work. They're very easy and quick, and it's nice to get the pulse ox too. We'll talk about what that is after we get to diagnostic testing, but actually getting the percentage of oxygen saturation, that can give us an idea of how well oxygenated that person is too. Okay. Okay, so now we go to respirations, and remember they're intertwined because the cardiovascular system is so intertwined together. The respiratory rate gives us an indication of how well the body provides oxygen to the tissues. This respiratory rate does work in conjunction with the pulse ox. We're not going to be doing the pulse ox yet, but that is something that also lends to how well the body is oxygenated. It can be a little bit difficult sometimes to get respirations. It's a little easier to get the pulse once you find it, but respirations can be a little bit trickier. You can do it a couple of different ways. You can watch that person's chest rise and fall. You can listen with a stethoscope, or you can even kind of place your hand over the top part of the chest and kind of feel for movement. And so people do find that this is a little bit tougher. Once the patient thinks that you're watching their respirations, it tends to affect their breathing rate. Sometimes they start to think about breathing and it changes it. So we'll go through some techniques in class to try and figure out a way to just kind of do it without alerting the patient that you're doing it so that they don't kind of subconsciously affect that rate. It is very important, though, when you're taking a respiration rate that you do it for a full minute. You can't cut it in half and multiply it by 2 like you do with the pulse, provided the pulse is normal. It's very important because you can miss some things if you try to cut it in half. So respirations you must take for 1 full minute or a full 60 seconds. And it's important to assess not only the rate, which would be in respirations per minute, but also the rhythm. Is it regular or irregular? And then looking for things like quality of either shallow breathing, deep breathing, or whether it's normal. There are a couple of terms that can be associated with certain irregularities. And if someone is in a case scenario where maybe they're anxious or maybe they have an underlying respiratory issue, they will sometimes be hyperventilating, where they're breathing in too deep and too quickly, which can kind of change the acid-base balance in the body and cause people to actually pass out. There's a couple of terms that you should have learned from medical terminology. The word dyspnea indicates that that person's having a difficult time breathing, and that could come from any number of things: asthma, pneumonia, pulmonary edema, anything like that. Any kind of cardiac or respiratory issue could cause dyspnea or difficulty breathing. Tachypnea is where you actually have rapid breathing, and then hyperpnea is where you're getting kind of deep, irregular breathing, abnormally rapid, deep, or labored breathing. So there's a number of different irregularities that can be noted when you're taking a respiration rate. There's something called rales, and rales is a sound that you'll hear generally down in the lobes the lower lobes of the lungs, and it has sort of a crackling sound, so sometimes you'll hear rales also called crackles. That generally indicates fluid in the lungs, and that fluid could be from a pneumonia, from a pulmonary edema, from congestive heart failure, or even an atelectasis where the alveoli collapse and you're not getting good gas exchange. So those are different case scenarios where you might hear something that's irregular or abnormal or not run-of-the-mill. Okay. Another sound that you can hear or note is something called rhonchi, and rhonchi is a little bit more associated with asthma or bronchitis, where you actually get sort of a rattling or a snoring sound, and this is because there's usually some sort of fluid obstructing the airway, causing sort of a deep rattling sound. And then there's something called Cheyenne-Stokes respirations. This is a little bit of an irregularity where you get an increasing and decreasing depth of respiration between episodes of no breathing, which is called apnea. These are usually strokes and head injuries. So this isn't a run-of-the-mill breathing pattern that you're going to see generally in primary care, but if you do ever have a case scenario to see that, it might be a little bit more you might notice it more or find it in an emergency situation is when you probably find that to occur. So, okay, so we kind of covered pulse and we covered respirations. So let's kind of take a look at blood pressure. Now, this is probably going to be the more difficult vital sign to assess and learn how to do because it takes quite a bit of time to become comfortable with it. And yes, there are all the wonderful digital apparatuses out there that can take it and do it real quickly, and you don't have to do it manually, but there are case scenarios where manualism is an important skill. There are times where batteries go down, electricity goes out, and you have to be able to take an accurate manual blood pressure. Okay, and so when you look at what the actual definition of blood pressure is, the force at which blood is pumped against the walls of the arteries. The standard unit measurement is millimeters of mercury. Now, we don't have those old-time blood pressure machines anymore that have the mercury that go up and down. However, that unit of measurement has still stuck, even though we don't have mercury blood pressure gauges anymore. Generally, you're going to see either an electronic, which is frequently used, but also called an aneroid. And so an aneroid is when you actually have a circular gauge, and you'll see the little increments. These are the ones that we're going to need to be able to learn how to do in class. And another important key to realize is there's a picture on page 745 that shows the numbers in the circular aneroid gauge. Each one of those little increments is 2 millimeters of mercury. And so you're not going to have odd numbers when you're doing an aneroid gauge reading. So the ones that we do in class, there shouldn't be anybody that comes up with an odd reading because each measurement, each increment is 2 millimeters of mercury. So we'll talk more about that. If you're doing digital, then the digital could give you an odd number, but not when you're doing an aneroid reading in class, okay? And so when we're looking at a blood pressure, we're looking at two different measurements. There's a systolic pressure and a diastolic pressure. And so the definition of these two is when you're looking at the systolic, that's usually the top number, and that's a measurement of pressure when the left ventricle contracts. The left ventricle is, remember, the part of the heart that has to pump the blood throughout the entire systemic circulation. And so our systolic pressure is the measure of that when the ventricle contracts. The diastolic pressure is the measurement. There's two ways of looking at the diastolic pressure. It's the measurement of the heart when the heart relaxes. And another way to describe that is the minimum pressure that's always exerted against the arterial wall. So there's two ways of kind of looking at the diastolic pressure. Essentially, we're going to be putting the systolic over the diastolic, and we'll talk about that in just a second. When we classify blood pressure, we're also looking at different stages. And if you look at table 37.4 on page 745, it kind of gives you the numbers that we're looking at as far as normal, pre-hypertension, stage 1 and stage 2, and then another term called malignant hypertension. So normal blood pressure is generally going to be under 120/80. That's what we're shooting for, okay? Anything under 120/80 is considered normal. Prehypertension is 120 to about 139/80 to 89. That's a prehypertension. A lot of physicians or clinicians will actually have started treating this prehypertension stage, because if you can't get that blood pressure down with exercise and weight loss and decrease in salt and what have you, dietary wise, there is a risk that it's going to eventually move into stage 1 or stage 2. And so when we look at stage 1 or stage 2, we can see that there's incremental elevation from that chapter. Stage 1 is 140/159 to 159/90 to 99, and then stage 2 is anything over 160/100. And so when we start, the higher we get, the more risk factor we have for end organ damage. And one of the reasons why blood pressure is called the silent killer is because people can walk around with prehypertension, stage 1 or even stage 2, and not know they have it and feel fine, okay? And so that's why a lot of people will not be consistent with medication, because they don't really feel like anything's wrong. But unfortunately, when you have high blood pressure for an extended period of time, it can start to cause damage to the small blood vessels in the eye, in the heart, in the kidneys, and in the brain. And what that is called is end organ damage. And so it is important to realize that controlling blood pressure is essential to decreasing that end organ damage. So the official term for elevated blood pressure is hypertension. Hypertension is actually the diagnostic classification or the diagnosis that you would write if someone actually had elevated blood pressure. Anyone that has two separate blood pressures over 120/80, if it's in the prehypertension stage, could be diagnosed with prehypertension. If you were to get two levels over 140/90 in two separate visits, you can classify that person as having hypertension, okay? It can be difficult because a lot of people always say, oh, I get nervous when I'm at the doctor's. It only happens when I'm stressed. It only happens when I go to the doctor's office. And so you're going to hear that a lot out in the field. And so it's important just to re-stress the importance of identifying hypertension and making sure, if it is identified, that that taking blood pressure medication as prescribed is important to decrease that end organ damage possibility. Okay, when we break down hypertension, generally most people are going to have what's called essential or primary hypertension, and the bulk of the cases are actually of that. A lot of that is it says unknown cause, but that could be being overweight. It could be improper diet. It could also be some genetic factors. And a lot of these people have parents or grandparents that have high blood pressure, and then it eventually just happens to them. It is a little bit more common over 40. However, I have diagnosed a lot of hypertensive cases in people between 20 and 40, so it happens. Prototypically, if someone is really young, you would look for something secondary. About 5 to 10% of the cases can be an underlying kidney or heart, or even something like hyperthyroid. So there can be secondary causes. A kidney tumor, number of kidney issues can sometimes cause the blood pressure to go up. So frequently doctors or clinicians will check and make sure there isn't something secondarily causing it, but the overwhelming majority is essential or basically unknown. There are different things that can affect and why high blood pressure happens. There's a number of internal factors. Something external could be stress. And so there are case scenarios for stress being a cause of hypertension, but we're looking more at internal factors. We're looking at a combination of these four things that are listed here. Cardiac output, as I had written in the other slide, is basically heart rate times stroke volume. Stroke volume is the amount of blood that's ejected from the heart with every heartbeat. And so if the amount of blood increases, which can happen in case scenarios where the blood gets too thick, or if there's something hormonally going on, or if the heart rate goes up, that can affect cardiac output and increase the output that the heart has to actually deal with. Blood volume can be an issue as well. So if someone is eating too much salt in their diet, which is causing them to retain too much water, then that can sometimes affect the blood volume, increase the amount of blood volume. That because it's part of the stroke volume, can sometimes increase cardiac output as well. And so that's one of the reasons why if someone has high blood pressure, a lot of times one of the first things a doctor will do if it's borderline or a clinician will do is start someone on a diuretic. And what the diuretic does is decrease, you urinate more, pulls out salt, pulls out some water so that you urinate a little bit more and there's less blood volume. Sometimes that's all you need to do to actually correct a hypertension. But prototypically somebody has to be in that pre or mild hypertension. If someone has severe, stage 1 or stage 2, a lot of times a diuretic alone won't take care of it. And they have to attack that blood pressure with different mechanisms. So 2 other mechanisms that can affect the blood pressure are vasoconstriction. Vasoconstriction is sort of the peripheral resistance, and that can be hormonally induced. That could be areas in the periphery that have buildup from lipids or from cholesterol, so that can affect vasoconstriction. And then blood thickness as well. When people's hemoglobin goes up, if they live in an area where the altitude is high, that tends to thicken the blood, or if they're in a scenario where they have something like COPD, which is chronic obstructive pulmonary disease, or a pulmonary issue, and they're not perfusing oxygen-wise enough, the body will then turn around and sense that, make more hemoglobin and more red blood cells, and that can cause the blood to be more viscous and more thick, and then the heart has to work harder to pump all that through. So all of these are internal factors that can affect the blood pressure. And then you could look at external factors such as salt increase and what have you. That comes from blood, that can affect the blood volume. So there's a number of different ways to kind of deal with hypertension, a lot of different classifications of medications to try to help bring it down. But the most important thing is to identify it, let the patient know how important it is to take medication as prescribed. And generally, clinicians will discuss with that patient as well as far as exercise and weight loss and dietary measures that can sometimes be tried first before actually having to go to medication. But ultimately, if medication is prescribed, it needs to be taken as directed. Then there's a situation where you actually have malignant hypertension. That's when the blood pressure is over 180 over 110. This can cause organ damage. This could cause a stroke or a heart attack. And so this is generally considered a medical emergency. And a lot of times these people are transported to an ER so that they can get medication in them right away. Okay. Hypotension, a lot of people will say, oh, my parents don't have high blood pressure, they have low blood pressure. Really and truly, hypotension in and of itself is not a disease process. Some people can walk around with a 90 over 60 and be completely fine. If someone has had internal injuries, have been in a case scenario where they're in shock, that would be a case where they could be vasodilating, the blood pressure can drop. That would be an issue, okay? Or if someone's taking a number of different medications for high blood pressure, maybe they're taking too much. And that's the case that we sometimes find with the elderly. So if you have an elderly patient that's on 4 different blood pressure medications and their pulse is low and they're complaining that they're dizzy, that would be an issue. But for the normal, healthy, run-of-the-mill individual, there really isn't an issue with hypotension if someone is actually dizzy or lightheaded when they stand up, okay? And I'll deal with that in class a little bit too. Okay, so we actually go through the actual, the piece of equipment that measures the blood pressure is called a sphygmomanometer. So it's going to be important that if you have to identify that piece of equipment that you don't call it a blood pressure cuff, you call it a sphygmomanometer, preferably spelled correctly. It's generally got an inflatable cuff that wraps around the upper arm. You can use the thigh, and there's actually times where you can use the forearm if you need to, but ideally it will go on the humerus or the upper part of the arm. There is a bulb that's pumped that puts air into the device, and then you can do the reading as the cuff deflates or as the air is let out. And then we'll talk about how to do this measurement in class. We discussed the fact that there's different ones. There's mercury. We don't sell those anymore. That was a column of mercury that would rise and fall. What we're going to be using in class is aneroids. We have them on the wall. We also, all of the portable ones have the gauge on the cuff as well. And then we will have an electronic one that you can practice with, but ultimately we have to be able to take in a blood pressure with an aneroid gauge reading. Each line, once again, measures indicates 2 millimeters of mercury, so we're going to have even readings when we go through aneroid readings. Calibration is important. It's always good to make sure when you have your sphygmomanometer that the gauge is at the 0 mark at the bottom. If it's moved, it's going to affect the reading, and so it's always important to make sure that your ones that are mounted on the wall, you take a look at that. If it's not, there generally are ways that you can adjust and calibrate it. Most of the time you're going to have someone in facilities that will come through and check your sphygmomanometers. Always take a look at it. If it is not at 0, notify someone and get another one and make sure, because otherwise you'll get an inaccurate reading. The other piece of equipment that you need in order to take a blood pressure with a manual or an aneroid is to have a stethoscope. Okay, and the stethoscope amplifies body sounds, and it is made up of 2 earpieces, and then there's some tubing, and then at the end you have what's called a chest piece. That chest piece has 2 sides to it. It has a diaphragm, which is the larger area that's got a piece of plastic on it, and then the other concave on the flip side is called the bell. The diaphragm is ideally used for higher pitch sounds, which would be the lung and the bowels. The bell is for lower pitch sounds, which are vascular and heart sounds. However, when we actually take a blood pressure reading, we're generally going to use the diaphragm, okay? And you're going to want to hold the diaphragm down. You don't really want to put the thumb over the top, because sometimes that can cause unusual sounds when you're listening, and so you're generally going to have to push down and not use your thumb, and we'll once again go through this in class, okay? When we're measuring, you're going to place that cuff on the upper arm. There's something called a palpatory method. This is prototypically used in the field when it's hard to hear and you want to get a vague idea systolically of where that patient's at. Those are usually trauma scenarios, and you want to cut. I don't know if you've ever watched any kind of emergency shows, and they'll say it's, you know, it's 80 palp, and that basically just means it doesn't give you a diagnostic reading. It just gives you the systolic, the top reading, but that kind of gives you an idea of what's going on with that person's cardiac. If it's low, that means they're bottoming out, they're bleeding, and they're gonna go into asystole. Okay. So prototypically what you would do, we can talk about the palpatory method. It gives you an idea of where to inflate the cuff too. So if you kind of start to palpate, you don't have to use your stethoscope for this. That's why it's called palpatory. You put your 2 fingers over the brachial artery. You pump up the cuff, and as you feel the pulse go away, that kind of gives you an idea systolically of where that patient's at, and that gives you an idea where your brachial pulse is as well. Then you can repeat it by pumping the area up about 20 to 30 millimeters of mercury above that palpatory result, and then you'll be in the ballpark of where that person is actually systolically. Okay, and we'll go through and we'll talk about what the air sound, or the air that you're listening to. That didn't make sense. I'm so sorry. As you release the air, there's sounds that you will either not hear or hear, and you'll start hearing the vascular sounds, and that will actually give you your reading. The sounds of the blood pressure reading are called Korsakoff sounds, and they're in different phases, and not every blood pressure will have each one of these phases. Phase 1 is prototypically sort of a tapping sound, and the very first sound that you hear is considered the systolic. So as you pump up your reading, so phase 1 is sort of a tapping sound. When the very first initial sound that you hear is the systolic pressure, that's where you would record your first number, and then you'll kind of notice a bit of a phase change where it'll get kind of softer. It'll turn into a swishing sound. Sometimes it will resume, and then eventually what happens is it becomes muffled, and then as the sound disappears, which is phase 5, that is considered the diastolic pressure. So you're basically recording from the time that you hear the beginning of the sound to the very end, and that gives you your reading. And you're going to record it as the systolic on the top and the diastolic over the bottom, either in a diagonal slash, it's listed there. Sometimes you'll see it as a horizontal line separating the two, but it will be in a dual number, systolic over diastolic. Okay. Things to look at when you're taking blood pressure is to actually make sure that patient is relaxed if possible. If someone has rushed in, if if they have some sort of disability, if they have known blood pressure problems, or if they're under any anxiety or stress, try to make sure that you let them come in, sit down, and relax for a few minutes. Sometimes people will opt to do some of the other temperature, weight, and stuff first, and then let the patient sit for a little bit before taking the blood pressure. If that patient seems that pulse is at 102, 106, and they seem, really physically kind of stressed about the situation, kind of talking to them, getting them to relax a little bit is a good idea, okay? There are certain time frames when you can't use a specific arm. If a patient's had a mastectomy, it's better not to use take a blood pressure on that arm. If there is some problem with the artery, like an implanted device under the skin, if they're going to dialysis and they've got a shunt or something like that, they're not going to want to take the blood pressure on that side. You also want to make sure you're using the proper size cuff. There is a pediatric cuff for pediatric patients. There's an adult regular cuff, and then an adult large cuff. And so if you use too small of a cuff on someone, it can falsely or elevate the blood pressure on the reading. And so making sure that you have a proper size cuff is important, okay? And we'll go through that a little bit in class as well. Now, there's something called orthostatic or postural vital signs. You'll hear them called orthostatics. And if somebody comes in presenting with dizziness or lightheadedness, generally you're going to want to see if there's a difference in their blood pressure in different positions. And so you'll hear the clinician will say, please take orthostatics. And so what you're checking for is something called a tilt test. And so if a patient's pulse or blood pressure drops with a change in position, then that can indicate that there's something going on, maybe, either cardiovascularly with them or even blood-wise with them. And so you're going to want to check the blood pressure and the pulse in three different positions, okay? All right, you're going to have them stand up, sit down, and then lay down. And so those three different positions, you will evaluate all three of those things. And if you see an increase in the pulse more than 10 beats per minute and the blood pressure drops more than 20 in either the diastolic or the systolic, then that's going to be considered a positive tilt test, and that would be positive orthostatics. That means there's something going on. Their vital signs are changing in their position. Prototypically, you won't get a huge change if that person's cardiovascularly intact, but if someone's having issues, then this would be something that would need to be checked for, okay? Now, when we talked about vital signs, the tail end of the vital signs, the body measurements aren't actually part of the vital signs, but they are taken in conjunction with. And so prototypically with adults and older children, you're going to want to do a height and weight. And generally, when you're dealing with children, you're going to want to get a height and weight every single visit. Once an adult has reached their full height, they will generally do it on the first visit and then maybe yearly. When you get to the geriatric population, sometimes they'll measure them a little bit more frequently, because when osteoporosis is a risk factor, then you'll actually see adults start to shrink, and that's because they're getting decreased distance between the vertebra, and sometimes even fractures can cause them to lose height. So prototypically, children are going to be measured both height and weight every visit. Adults will be measured initially and then yearly, but once again, a geriatric patient might be more frequently. You're going to measure to the nearest quarter inch, okay? So it's not going to be eighth, it's not going to be half, it's going to want to be at the quarter inch. When you're dealing with weight, this is the one that's a little touchy, especially with females. A lot of females will deliberately not go to the doctors because they're afraid that the doctor's going to yell at them when they're overweight, and they don't want to see their weight. So I've known many, many people that have put off going to the doctors because of this issue. So it's very important to be reassuring, don't judge, and make sure that they're comfortable with this. And so making sure there's the ultimate of privacy with weight measurements is important too. You're going to want to take a weight every visit. There are going to be some people that will decline it, and you'll have to talk with your facility on what to do if a patient declines to have their weight done. Okay. When we're dealing with infants, not only do we do length and weight, but we also do head circumference. That head circumference is a very important part as to whether or not that child is growing appropriately. We won't do these measurements in infants now. When we get to the pediatric chapter, we'll go through these at a little bit more in length. Prototypically, when we're dealing with those, we're going to make sure we're measuring them every single visit. And that head circumference and those measurements are really important because it's important to establish baseline values, because if children are not measured correctly, it could be or if they're not growing properly, it could be a sign of failure to thrive. And so getting accurate measures on all three of those is essential, okay, because that really establishes whether or not that child is growing and developing appropriately and compared to other children, okay? And then also when we're doing weight measurements, we're going to do it to the nearest quarter pound. So whether it's an adult or even a child, we're going to measure to the nearest quarter pound with weight and to the nearest quarter inch with height, okay? And then lastly, we don't have to measure the nice BMI is the body mass index, and it's a pretty good indicator of a healthy weight, and it's based on height and weight. And the EHR actually will calculate this without having to do it. There's actually an extensive thing that you can do, not extensive, but there's a mathematical equation you can do to figure it out. But most EHR will actually calculate this for you. For the most part, with normal individuals, it's a very good reliability on healthy weight parameters. What sometimes happens, though, is when you're dealing with a bodybuilder, muscle mass weighs more than fat, and so a lot of times a bodybuilder will come in at an obese or overweight or obese category, but they might have a very low percentage of body weight. So the BMI does work for average individuals and most people, but there are some case scenarios where you would have to make an exception and look at some other parameters when you're dealing with a bodybuilder. Okay. And other things that might be measured, we talked about height, weight, and head circumference. There are other times where you'll need a tape measure of sorts to measure other body parameters. Sometimes you have to measure the diameter of a limb. If you're looking at the lower leg, if somebody's complaining and might possibly have a deep vein thrombosis in their calf, you're going to want to measure both to determine the difference in size, because if one's bigger than the other, it could indicate that there is a deep vein thrombosis present. Anytime you have a rash or a wound or a bruise or any other injury, you're going to always want to measure the length and the width of it. Even a breast mass, any kind of skin lesion, you're going to want to measure it, because if it's changing, you want to document the measurement so you know later on if they visit whether or not it's getting bigger or smaller. There's case scenarios where they might measure the infant's chest circumference. If there's respiratory issues or cardiac issues, you might also throw in a chest circumference. And then there are also times cardiologists might do an adult's abdominal girth. The abdominal girth size can show an increased risk for cardiac disease, whether it's male or female. You have a large, if your abdominal girth is larger than your chest, then that's a higher risk for cardiac disease. And so there may be some facilities that would measure an abdominal girth. Okay. And so, in summary, we covered quite a bit here. We'll go through in class and demonstrate how to do the vital signs, the different ways to take temperature. We'll learn how to take a pulse and respirations, and then we'll go through and talk about the blood pressure and how to do it in class. We'll go through and show the different areas that you can take a pulse. It will be important when you're doing the blood pressure and pulse and respirations that you actually have quiet. It's going to be a little difficult in our class area just because people do kind of talk, and so we are going to have to try to keep our voices down. It's very hard to hear with some people's blood pressure if there's a lot of external noise. So being in a quiet area, which is why most facilities will have a closed room to take this in, just because if you have to do it, it can be hard to hear. And then we'll talk about the postural vital signs as well, and at times when you would have to do that, and then just realizing that height and weight are going to be done. You're going to have to go through and take 15 sets. We'll We're going to focus on adults now because that's what we're dealing with, but we'll go through and do the infant measurements when we get to chapter 40, I believe. Okay? So that kind of comes to the conclusion of this. We'll go through a lot of these in demonstrations, and that's going to be the end of 37 for now. Okay?